I'd like to welcome the local custodians of the land on which we meet this evening and honour elders past, present and emerging. Welcome. Tonight we're having common diets for weight loss and a comparison of evidence with Emma Bone presenting. We'd like to welcome Emma and yourselves this evening. Just a little bit of housekeeping. The chat box we'll utilise for any questions that you may have. Any questions that we run out of time with, we can email through to me at the education email or my personal email, mwilkinson@hneccphn.com.au. That's also on your invites as well if you didn't catch that. And I will forward those to Emma to answer. Tonight it's being recorded. You'll be able to access that through our website in the Education Library. There'll be a poll at the end, which we would love you to complete. That gives us feedback and your input's really valuable to us for gauging events and future events. So I strongly encourage you to complete that. And I think that is it for the moment. So I'm going to now introduce Emma. Emma's a practicing dietitian. She's worked in general practice for quite a few years before joining Hunter New England Greater Newcastle Diabetes Service. She's worked on several research programs and has been heavily involved in CDM, childhood nutrition and weight loss. So I'm going to hand over to you now, Emma. Enjoy.
For that, hi everyone, nice to join for a really interesting topic of discussion. I think I've only done this presentation once before, so yeah, it's really quite an interesting topic and I really enjoy this body of work. Basically, I want to acknowledge the dietitians that I work with. Their names are down the bottom, especially Josephine Engerfield, who did this presentation and we developed this body of work together. So all the dietitians are fantastic and we've made a pretty amazing little bit of work which I'm going to share with you tonight. So what this presentation will include is a comparison of a different number of diets that we usually get asked about, or our doctors ask us about, or anyone asks us about, really. I think when people find out I'm a dietitian, I get asked a lot of questions, even in the supermarket, on the street. And yeah, what we thought we'd look at is really some of the evidence surrounding some of these common diets that people do to help with them with weight loss or to help manage and control their diabetes. So we each of the dietitians, we each looked at a particular diet and looked at some of the evidence and compared them. So this presentation is going to look at each diet individually, some of the benefits, some of the risks, what the overall evidence is and what we like to kind of the key messages that come from each of those diets. Not all of them are bad, not all of them are good. So that's kind of what we wanted to compare as a number. So this body of work came from with our Diabetes Alliance, which is when our diabetes team from Hunter New England Health go into the GP practices, and we work with the GP staff and our staff with patients. So they were asking us to our opinions and some of our evidence of certain diets that their patients talk about with weight loss, diabetes management. So for example, one that we always get asked about is low carbohydrate and ketogenic diets, and whether they're evidence-based, whether they're useful, and whether that's something that we would recommend. We also hear about various and frequent diets, not just from the Alliance team, but from other healthcare workers that we work with in our building. So we work with a lot of other allied health, nursing, medical staff. So, and sometimes we hear bits and pieces, whether they have limited clinical evidence, and some of these messages that are getting delivered by some staff, it's a bit concerning because it's conflicting evidence and conflicting information that from our side of things as dietitians, we try to give the best recommendations. And our head of diabetes, Dr. Dietary, requested this resource to be made from the diabetes dietitians to use in Alliance and the medical clinic. So what he asked was, can I have a 2-page document of just some of the key messages and some of the evidence of these diets? And it's a really helpful and useful resource. I think it is available on the Primary Health Network website. I'm going to show you a little snippet of what it looks like. It is available, as I said, I think on that website, or if you can't access that, we are able to provide that. So it's a bit of a summary of everything that I talk about today on a 2-page resource. So the diets that we looked at and we analysed were the ketogenic diet, the paleo diet, vegetarian or vegan diets, intermittent fasting, a very low energy diet, or what we call a VLED, dietary approaches to stop hypertension, also known as DASH diet, and the Mediterranean diet. So a comparison of all those different ones, and they're the common ones that we hear. And we get asked about whether we support, recommend them, or we don't think they're a good idea. So the components of the table on the resource include the key elements, like what is included in this type of diet, the main exclusions, as in what parts of the general day-to-day diet are excluded when we follow these diets, whether they have any weight loss, whether they have any benefits, risks, and what is the long-term evidence and adherence. You can see that that's what it looks like. It's a 2-page. It is a very wordy document. It was very difficult to keep it to 2 pages, but we did our best. And you can see all the different diets are across the top, and then it goes down, key elements, main exclusions, evidence for weight loss, benefits, risks, and long-term evidence and adherence. And we also have, I think, a table of references included in that as well. Now, given this table was completed mid-2019, so there could be some new evidence coming out for each of those. This was completed back then, so there's always new and evidence occurring frequently. So let's start with the ketogenic diet. Basically, a ketogenic diet is a very low carbohydrate diet, which means it's moderate in protein and also high in fat. So I found when I was doing the evidence and looking into ketogenic diets, it was highly variable about how much carbohydrate you were allowed on this diet. Generally, carbohydrate intake was less than 10% of the energy per day. So approximately 20 to 50 grams of carb per day, which is very minimal, which could be, it could be a banana, or it could be maybe a cup of cooked rice. That's the variation. So very little. It is different from other low carbohydrate or low energy diets because the diet remaining is very, very low in carb. And it keeps the body in a state of ketosis, even if the total energy increases. So it's very interesting that how popular these diets are across the board, even in our local area. I know that for our gestational diabetes patients, it's extremely hard to get keto diastics, which is something that we get our gestational diabetes patients to check their ketones in their urine every morning to make sure that they're getting enough carbohydrate in their diet. And they have a really hard time accessing those keto diastics because so many people are buying them to see whether their ketogenic diet is working. So yeah, it's very interesting how popular it has become. So ketogenic, you can see there is many different variations out there. It has a very big list of foods to avoid, foods to include, lots of rules. But is there weight loss? So we have found that the short-term weight loss will occur because you're reducing a total energy or kilojoule intake. And usually you're reducing a lot of those foods that the fast foods, the takeaways, what we call less healthy discretionary food choices. So when you go onto a diet, you essentially will lose some form of weight because you are changing your food choices. But in regards to ketogenic, you're really reducing total kilojoules, which come from the carbohydrate. And we also see the depletion of the liver and muscle stores, which associated with water loss, which will reduce your appetite. Therefore, you don't feel hungry, you don't feel like you're eating as much. So long-term weight loss, though, which is what we really want, is really unlikely due to the highly restrictive diet being unsustainable over time. A lot of people can't stay on it. It's a very bland, boring diet. I don't know many people that have, I think the longest I have heard was 18 months, but that person did tell me that they, I think, went in and out of the ketogenic diet. So for long term of solely just on the ketogenic diet, it's really highly unsustainable. So we only see transient weight loss because it's a short-term effect. And then we see a really high weight gain when they go back to usual eating, which is always that rebound weight gain from any diet. You restrict your intake, you lose that, go back to normal practices because you get sick of a certain way of that restrictive eating, and that weight gain comes back on, sometimes even more so. There are a few benefits, and I like to highlight that, you know, all these styles of eatings do have positives and negatives. And I like to, when people ask me about them, I do kind of not just focus on the on negatives. I try to talk about everything in the essence of the diet. What were the reasons that people have picked that? So the benefits of a ketogenic diet are potentially decreasing that HbA1c due to the weight loss and lack of carbohydrate. So without carb, we're not going to have that much sugar uptake. Therefore, blood sugars will be improved, and so will the HbA1c. But again, long term, it depends on how long you're on something like a ketogenic diet for and whether it will affect that HbA1c. Some research do suggest that there is improvement in lipids because of the weight loss, but the majority found that there is a lot of increase in LDL cholesterol particles because the diet is highly saturated fat. It doesn't differentiate between which are better fats. It just ensures that you will get the fat instead of carbohydrate. And it may improve that fat oxidative metabolism, although mechanisms are not so well understood. So there's not a huge amount of, there was a bit of conflicting evidence for the benefit. So the risks, basically the one key one that I talk to people about in general is unable to meet the core food group recommendations. Now the core food groups basically are the 5 food groups. So it used to be a pyramid, now it's a plate. Your core food groups: fruits, vegetables, dairy foods, meats and alternatives, grains. So when you're on a ketogenic diet, a lot of the time you're missing out on a lot of the good food groups because carbohydrate comes from pretty much all the grains and cereals, some vegetables, mostly the starchy ones, fruits, most fruits, it gets rid of that group. It will get rid of milk and yogurt, so it takes away some of the dairy and some of the legumes, lentil-based parts of the meats and alternatives. So there's a large chunk of that core food group foods being taken away. Especially without that grains and cereals, it reduces the overall fibre. So it's a really low fibre intake. Fibre is a really important part of the diet. With the excessive protein intake, usually it's a high amount of the processed meats. It does increase that risk of bowel cancer. So it's a low fibre and the excessive protein coming from sometimes those processed meats our cancer risk increases substantially. And the higher fat intake, as I said before, will increase the risk of higher lipids. So cholesterol does get varied in the pathology. One thing that I really stress with my patients, my diabetes patients, there's a high risk of hypoglycemia because when people are on insulin or even some of the glucose lowering medications. We're not having carb, we're taking insulin to reduce our sugar in blood sugars, we're going to hypo. It's extremely problematic. And also the increased nitrogen secretion, which can lead to possible renal damage. So ketogenic diet does have a few risks, and it's not, one that I'm a huge fan of personally. However, when we do get people that are interested in something like a keto diet, we don't dismiss it completely. We talk about how we can still include some healthier options and how we can work with the patient to make sure that they're safely following something and getting the adequate nutrition. So you can see that this keto food list, it really, you still get a little bit of fruit because berries are low carb. They focus a lot on nuts and seeds, cheese, different variations of milk, non-starchy vegetables, meats, fish, and lots of heavy fats. So, but the only thing is every keto pyramid or keto food list is slightly different. There's never a common ground, which is what we find is a big issue. So long-term evidence with the extremely high dropout rate seen in weight loss studies and even the epilepsy studies, because that's something that they usually have trialed to help with epilepsy, because there's poor tolerance of the type of diet due to its restrictive nature. Long-term data regarding weight loss, diabetes control, and improvement of other comorbidities. So generally, from a dietitian perspective, we don't recommend it. But as I said, we work with every patient to ensure that they're supported in their own dietary choices. So the next one is very similar. It's the Paleo diet. It refers to eating how our hunter-gatherer ancestors used to eat. And it includes a diet based on protein like meat, fish, chicken, and eggs, fruit, vegetables, nuts, and seeds. So it excludes a lot of the processed foods and a large selection of carbohydrate foods, bread, cereals, grains, legumes, milk, yogurt, cheese, and some oils. So a little bit different to that ketogenic diet. You can see here the paleo and not in the paleo. It's become quite a movement. It's kind of more of a, it's even become a way of life for a lot of people. There's a lot of paleo packaged foods. It's a brand now. And yeah, there is a lot of people that support it, and especially when it comes from people in our media that drive that paleo diet. So is there weight loss? So there is no high quality long-term studies regarding the effect of a paleo diet and subsequent weight loss. So there are some studies that suggest about 3 to 7% of total body weight loss due to, again, the overall decrease in calorie or energy and kilojoule intake because we are consuming less of the processed or takeaways food. So there is that weight loss initially. Some other short-term benefits could be the satiety aspect again, because I guess it is lower carbohydrate. We're having that water reduction effect, which causes early satiety. Plasma lipid levels, and also, sorry, next is covering my thing there, and blood pressure. Increased insulin sensitivity and lower fasting glucose. So again, there's just little short-term benefits. And a lot of the time when people undertake these diets, those short-term benefits are the things they want to see straight away. And as soon as they see a little bit of benefit, they're quite adaptive to going, I'm going to stick on this because I can see something happening. The benefits are mainly from weight loss after reducing total energy, not the diet itself. So another key concept that's in paleo is the same as the ketogenic diet. So risks of the paleo diet. Again, we've got hypoglycemia, reducing a lot of carb and carb food groups. Therefore, we're going to be reducing our blood sugar. There's also changes to digestive health and increased risk of bowel cancer because of the high meat intake. Meat is a really prominent part of some of these diets. And yeah, that can really, and a lot of the processed meats, there's a big link between those and bowel cancer. Also a deficiency in calcium and a decline in bone health. That's a really big one, and we want to make sure that we're getting that calcium because over time and as we get older, that bone health is really important. Associated with higher sodium intake, a lot of the processed meats will have a higher salt. And the higher saturated fat intake as diet promotes coconut oil and butter, which are really high saturated fat foods. Higher saturated fat will increase your cholesterol. Butter is always butter versus margarine is always a constant debate, and it's still the evidence from the Dietitians Association of Australia, where we recommend the poly or monounsaturated fats, which are your plant-based margarines, rather than your saturated fat coming from butter. Long-term evidence of the paleo, there is no long-term evidence. Again, very high dropout rates, poor compliance. Something really interesting around this one is that it's a high one to follow because of the cost and adaptability. It has a lot of wild meats. If you look at some of the diet prescriptions, but it does promote fruit and vegetables, but fails to provide all nutrients due to exclusion of whole food groups. Something that I'm really wary about when I'm looking at variable information regarding diets is what are they cutting out? If it's a whole food group, for example, dairy, then it's always a bit of a worry because there's a reason those 5 food groups are combined for evidence for overall good health. They each have their own benefits. Now, the vegetarian and vegan diets. So basically a vegetarian diet will exclude meat products, usually does include dairy foods or eggs. There's different variations of vegetarian. Vegan excludes all animal products. So no meat, fish, dairy, cheese, yogurt, honey, etc. It can be often chosen due to religious or ethical reasons. So that's usually the driver of a vegetarian or vegan. So therefore, they're a little bit more long-term to be followed because people have more of a reason for following that. Is their weight loss. So vegetarian vegan diets in particular appear to have some beneficial effects on weight reduction and lowering your BMI. And benefits are often attenuated over time. But they still require those longer term intervention trials to investigate the effects of vegetarian diets with weight control and cardiometabolic risk. We still haven't got a huge amount of longer term evidence and studies. But as I said, it is likely that if people do become vegetarian or vegan, mostly vegetarian, they are able to follow it longer term. Vegans may start off as vegans but fall back into the vegetarian category because it's a little bit easier to manage. But yeah, definitely see more vegetarians as a longer term option than people following such as paleo or ketogenic. So there is modest weight loss with vegetarian or vegan diets because, again, calorie intake, there is a lot of calories that come in some of those animal products. You're also really increasing and improving your intake of fruit and vegetables, which are associated with longevity. We do have a decreased saturated fat intake, which is great for heart health. The saturated fats predominantly come from those animal products. Therefore, less of the saturated fat means better, good quality fat for your cholesterol levels. Actually helps improve insulin sensitivity. It can lower rates of some cancers, and it can help decrease your blood pressure and heart health. Again, meats are usually associated with a high intake of salt, so that's why the blood pressure is great. The risks, though, we do see iron deficiency and B12 deficiency because we can't absorb plant sources of B12. So you may need to be on a supplement for B12 if you are not having any meat. Menstrual disruption, calcium deficiency if you've cut out any dairy, especially if that's for the vegans mostly. Protein deficiency if you don't replace your protein alternatives to meat, which I see quite frequently, where people are just having vegetables for dinner rather than replacing a steak with something like tofu or legumes. Omega-3 deficiency, and vegans especially need to consider the supplementation of particular nutrients such as B12, iron, omega-3s and zinc. There's a lot of missing nutrients from a vegan side of things. And again, it's about us understanding the background and their reasons for choosing to be vegetarian and vegan. It's not that we're going to completely dismiss the reasons for them choosing to have those diets. It's about working with them so they get the adequate nutritional benefits across the foods that they can eat, and what can we give them to get those nutrients that they're lacking. So there is some long-term evidence where it's somewhat protective. So you can see I like this little picture here because it shows you a comparison of calories. And the main thing is it increases your fruit and veg intake, which is always a positive in a dietitian role. And that means better lipids because more fruit and veg improves your cholesterol and less intake of the cholesterol, the high cholesterol foods. Intermittent fasting. Now, this one is quite an interesting one as well. Again, it's quite variable in how you do the intermittent fasting. I've seen multiple different levels of intermittent fasting, types, days and structure. Basically, it's restricting food and drink intake to about 0 to 25% of energy needs 2 to 3 days a week. So you have some days where you completely fast or you have very low energy intake or food intake, followed by normal healthy eating or on non-fasting days. You can see here it could be equal to, for example, 500 calories or 2,000 kilojoules for women, 600 calories or 2,500 kilojoules for men, which is approximately, 25% of total energy needs for an average human. On fasting days, there must be limiting of foods containing large amounts of carb, protein, fat, and that helps reduce the overall energy intake. So you can see a couple of examples here where a lot of people you can see the one on the left, people fast until around lunchtime and then they start their day. There's another one. A lot of them do skip their breakfast and, go from evening after their evening meal all the way to the next day around lunchtime. That's the usual pattern, but sometimes they can be a little. Is there weight loss with the intermittent fasting style diet? So again, short-term intervention studies show that we can reduce body weight and fat mass between 3 to 12 kilos. So pretty good weight loss. However, no evidence that we could find regarding the efficacy and effectiveness of intermittent fasting for long-term weight loss. Again, high dropout rates. Even in the short-term studies, there were really high dropout rates. Long-term maintenance must be considered. Is this something that people can do long-term? Benefits, yes, weight loss, we've just kind of discussed that. We do see a reduced fasting glucose, insulin levels, improved insulin sensitivity, and lipid profiles. However, limited high-quality long-term studies with these control groups. So, mechanism behind the benefits is due to the overall energy calorie restriction. Again, that overall, I'm going on a diet, here's what I'm going to follow. I'm going to have some reduction in some of those treat-based discretionary foods that are high calorie, therefore weight loss will be evident very early on. There are a lot of risks as well. Overeating on non-fasting days and an impact on mental status. I have heard of, and I haven't seen it as much, but I have heard of people that are on these style diets where basically the days where they don't fast, they can eat whatever and how much they want, which can be concerning because, first of all, is it going to basically not throw back the entire work that you've made over the last few days of fasting? So is it really going to have no benefit after all? But also that binging behavior, that is going to impact your mental status, where people kind of all or nothing theory, where food can be seen as, you know, there's a lot of and a lot of psychological aspects of this style diet that we have to be aware of, where we don't want people getting that behavioral mechanism from not being able to recognize their appetite. Definitely not suitable for people at risk of or with a history of eating disorders, because it is that binge purge kind of relationship which we are trying to help people stay away from. On those fasting days with diabetes, we may need to look at your medication to be changed because, again, risk of hypoglycemia, whether it's you're on insulin or an OHA, some of them will reduce your glucose levels. So there may be a medication change where we need you to have more insulin on the days that you are having something to eat, and especially if it's a complete all or nothing day where you can eat as much as you like, medication may change substantially. And risk of nutritional deficiencies in extreme fasting cases, because you're still cutting out a bunch of food and a group of foods that have micronutrients that are important for different aspects of the diet. So we couldn't find any long-term evidence with the intermittent fasting. Short-term studies have ongoing issues because of adherence to fasting days because of the restrictive nature. It is it's a lot different to the keto and the paleo style, where they're still having something to eat. They've still got some energy consumption, but some of these fasting diets are a long period of fasting, which can really be a big issue. And people are just finding it's too risky and restrictive for them. Let's do a time check. Okay, so next up is very low energy diet, or something that we refer to as LED. This is something that in my day-to-day I do see a lot of. I work with a lot of people on these types of diets. So basically what it is nutritionally complete dietary preparations. They can come in the form of shakes, bars, soups, desserts, and we usually only recommend OptiFast or OptiSlim, not the other products. There is an absolute huge amount of other products in the supermarket these days. Big favourite is the lady and the man shake. There's, Tony Ferguson. I'm trying to think of some other ones, but yeah, there is so many out there. The difference is that we can't have them as part of our diet. They don't give us everything we need if we replace all meals with a product. So generally their aim to be obviously reduce calorie or energy. So it can be about 800 calories to 3,300 kilojoules per day, depending on the weight of the person. And we usually do some calculations. We usually do a person's adjusted body weight based on their BMI at 25, or healthy weight, and then we do some calculations to work out how many products people need, how much extra protein people need, or whether protein is solely from these Optic Fast or OptiSlim products. We also calculate the fluid requirements. Fluid is extremely important because as your body goes into ketosis, which means you're breaking down the fat in your body, you can become quite dehydrated. We usually include 3 products, a specified amount of water, at least 2 cups of vegetables, and usually we need to add a little bit of oil if people still have their gallbladder, and it's to stimulate the gallbladder working. There are different levels of a very low energy diet, so you can replace all meals a day up to maybe only 1 meal a day. And there are different levels in each of those phases. So we start, I mean, anyone can start at any level, but if you do start at the very first phase, you'll see that you'll have all meals replaced. And then the second phase, after 12 weeks, it's 2 meals replaced with the introduction of a meal. And we usually start to introduce some fruit and dairy and protein foods. So we kind of to people through each and every stage so that they can reintroduce healthy, balanced meals back into their day-to-day. So there's a little cycle of the VLED phases. Each usually goes for 12 weeks, approximately, starting at 3 products a day, to 2 products a day, to 1 product a day, to 3 complete balanced meals. All up, it can be up to 40 weeks. Weight loss, there is an average of 1 to 2.5 kilos weight loss per week in the intensive phase. It has really good weight loss. However, it's highly variable between individuals and changes as the weeks go on. Obviously, you're going to see more weight loss with the intensive phase because you're replacing more meals with those low-calorie products. On average, by the end of the program, it's 9 to 19 kilos total weight loss, and 7 to 13 kilos after 1 to 2 years. So that's good longer-term evidence is people adhering to. It is very challenging. I have tried it myself, and I did not fare too well. I found some quite positive. I find it quite interesting to give things a go. Exactly what are the challenges behind some of these? So the benefits generally are the excelled weight loss. You see the weight loss occurring more so, and therefore it keeps you more motivated. It suppresses ghrelin and assists in appetite control. So usually in the 3 days, we call it a 3-day challenge. You might be a bit nauseous, as I did, or extremely hungry. And after 3 days, your kind of appetite regulates itself. It's due to the ketosis, and that ketosis and protein intake may also help suppress muscle mass loss. So it's losing fat, not muscle mass. There have been shown to be improvements in blood glucose levels, insulin resistance, lipids, blood pressure, and other health associated with weight loss. But the thing that's really important about this is supervise it. It's medically supervised by dietitians, and usually diabetes specialists. And even our diabetes educators are in a role. Oh, just checking my audio is coming back. Hopefully it's forward. Oh, audio's back. Awesome. So yeah, this is a really important aspect of it because there are quite a few risks and safety aspects associated with this diet. We need to supervise, and there is a lot of supervision and support through the BLED. So risks, and this is why, again, we supervise it so so closely. Hypoglycemia. When we've got our patients, all my patients that I see have diabetes, we need to make sure that people are not having this frequently. We usually get our educators involved if they're on insulin, and we get them to titrate the insulin while they're on the program. So we have regular contact with the patient. It does help lower your blood pressure, which means lowering your blood pressure medication usually. Sometimes they come off blood pressure medication. Electrolyte disturbances, yeah, so that can also occur. So we monitor pathology pretty closely. And some of the low blood pressure is something we also check. We check people if they're getting dizzy, and sometimes, as I said, those medications need to be reduced. So sometimes getting in touch with the GPs and yeah, making sure that people are not at a safety risk. There can be some gut issues associated with BLED. Headaches, very common occurrence if people are dehydrated, not getting their fluid requirements. Pancreatitis, gallstones, hence why the need for the oil with the to stimulate the gallbladder, because it is it's lower in fat. Gout is a risk. People before they start it, we usually get them, they've got some sort of gout medication before that. And there are some menstrual cycle changes associated with rapid weight loss. A lot of people we find, if they've had a really hard time falling pregnant, they become quite fertile because their menstrual cycle changes. So we usually do not encourage it if people are, you know, and if people are not on any contraceptive medication and don't want to be falling pregnant. So there's also a long list of cautions and contraindications, including excessive loss of muscle mass and skinny disease. There's a big clinical treatment protocol, and when we have patients, what I usually do is we go through a bit of a referral process. So we ensure that there is a plan in place for their medication adjustment. We check that they're going to be having reviews with their GP or their diabetes specialist to make sure that, you know, if there's any abnormal pathology or blood pressure issues, we can sort that. And we check, you know, if people have any of these contraindications, that they don't start something like this. Age is a big factor as well. We don't want anyone over the age of 65 trying something like this because it can, the muscle mass is the big issue. We want to preserve that muscle mass in patients. So we always look at, yeah, clinical treatment protocol is available on the OptiFast website. It's updated very frequently, and we use that to guide day-to-day. We have evidence. There is a large body of evidence over many decades. It's one of the first diet that actually shows some longer-term evidence. It does show effectiveness in weight reduction and maintenance for fast phases. They're really highly, the patients are highly supported through these processes, we find. So they're more likely to have that accountability when doing something like this. And a lot of people say to me, well, it's good because I know I'm checking, so therefore I keep up to my following of the diet. Patients, what we aim to do as well is introduce healthy portion control in general healthy eating by the end of the program. We want people to stay on the whole program so we can introduce these key concepts. The only issue is that I see is a lot of people do the intensive, the starting phase, maybe the second phase, and then they get a bit tired and they drop out. And we haven't had the chance to get to the portion control, the general healthy eating, that part of a very low energy diet, which means that sometimes we're back where we started a couple of years later, where they've regained the weight because they haven't learned those key concepts. And the other side of it, where people get so nervous about reintroducing food, they want to stay on these products long time, forever. And that's not normal, usual behavior and eating. And that can be a bit of mental health issues with that, and that's something common. We really are quite selective in who we find is really appropriate for something like a VLED.
Emma, it's Mel.
Yep.
It sounds just a little bit distorted on your end. It must be an internet connection issue. So I'm just going to ask, would you mind just turning off your camera, and that may help?
Yep.
Fingers crossed. Thanks, Em. Thank you.
Problem. My poor old computer is, you know, getting old. It's got me through uni, which was a good 10 years ago, so poor thing. All right, where are we up to? We're up to this next part. We're up to the dietary approaches to stop hypertension, or the DASH. So the DASH diet usually promotes fresh fruit, vegetables, whole grains, low-fat dairy, fish, poultry, legumes, nuts, and good quality vegetable oils, which are pretty much part of the core 5 food groups. Limits salts and high salt foods because that's really helpful in managing blood pressure. It limits foods high in saturated and trans fats like fatty meats, full fat dairy, tropical oils such as palm oil and coconut oil, high sugar foods, sugar sweetened drinks. So overall, it looks very similar to the Australian Guide to Healthy Eating, which is our basis of a good healthy diet. So you can see with the salt, it's limited to under 2,300 milligram per day. So it's got most of the, as I said, the food groups here. You can see that it recommends 6 to 8 servings of whole grains, 4 to 5 servings of vegetables, 4 to 5 servings of fruit, 2 to 3 servings of fat-free or low-fat dairy. Now, the reason it's recommending that fat-free or low-fat dairy is because dairy is an animal product, therefore it's going to be saturated fat. Therefore, the fat that comes from milk, yogurt, it's going to be saturated, so we want the lower fat versions. Then you can see 4 to 5 servings of nuts, seeds, and legumes, less than 6 servings per day of lean meat, poultry, and fish, less than 5 servings per week of sweets, and 2 to 3 servings per day of fats and oils. So I think this is the first diet to actually acknowledge discretionary or treat foods, which means that it's really interesting. A lot of the diets, they cut them out completely. It's just non-existent in the diet. So I really like to acknowledge when I'm talking to patients, you know, it's not that you're never going to be allowed to have these foods again. There's got to be room for practicality of those aspects of the diet returning for special occasions and treats, but really identifying them as a treat food, not an everyday food. So I do like that about the DASH diet there. Is there weight loss? The DASH diet, in addition to exercise, could assist with up to 6 to 8 kilos of long-term weight loss for those who are overweight or obese. So again, mechanism is believed to be from the total energy reduction after limiting exclusions, which are energy dense and nutrient poor. It is a nutritionally complete diet, which means we're getting all the foods and the food groups with the micro and macronutrients that we need. That good satiety will also help with long-term weight maintenance. Benefits and risks. Research reveals the DASH diet assists in weight loss, blood pressure lowering, and lowering the LDL cholesterol and increasing in the good cholesterol of the HDL. Overall reduction in heart disease risk. There are no associated risks reported or hypothesized. It's a overall balanced diet with decrease in undesirable food choices. As I said, this is one kind of diet that we have identified as one that we do like because it's no exclusions. It's really highlighting the difference between what's an everyday food and what's a treat and a less often choice, which is something I always drive home to patients. If a diet is going to restrict and cut out anything in particular, it's unlikely we're going to keep going with something like that, or we're going to get those cravings. If we know that, yes, we can have those treats, we can enjoy them, it's just making them less frequent and in smaller portions. Long-term evidence for the DASH, it has really good long-term adherence because it's practical. Helps us change good dietary habits. We do see weight loss, decrease in blood pressure, seen many years after the initial education counselling regarding benefits and how to follow the DASH diet. It's been around for a while, and it's again, it's more inclusive, and that's the good thing about it. Another, and this is the final one we're going to talk about, Mediterranean diet. So this one is a relatively newer one that's been researched recently, and it focuses primarily on a plant-based diet, including lots of vegetables, fruit, legumes, whole grains, beans, nuts, seeds, herbs, spices, and olive oil. It actually, the thing I like about this one is the holistic approach. Fresh food, cooking, lifestyle, exercise, and social life. It really draws together the fun side of preparing food, it being a social thing where we enjoy it. The thing I don't like about some of the restrictive diets is the negativity associated with a lot of those. What are we not allowed to do? What's given those negative words associated with some of these poor foods? This Mediterranean diet is really great in it. It shows what are the good foods, what is the great and positives of food, and how can we enjoy it as much as possible while still getting health benefits. It promotes moderate fish, lean protein, and eggs. And one wonderful aspect, one small glass of wine can be consumed once per day with a meal. Love it. So it's kind of an inclusive but yet healthy diet. So some of the exclusions, limited to less than weekly. Again, not cut out and not allowed to have. It's just let's limit it a little. Red meat, not that red meat is a poor food. It just means that we're focusing on different aspects of protein. Sugary drinks and foods, snack foods, sweet and savoury pastries, processed meats, refined grains, unhealthy fats, deep fried foods and takeaways. There's a nice little pyramid there as well, where you can see there's lots of fresh fruit, vegetables, nuts, oils, good, healthy, lean protein sources. So there really good evidence for weight loss. Large-scale meta-analysis reported significantly reduced weight by a mean of 1.75 kilos in the short term. Larger reductions in body weight were observed when diets further restricted energy. So, you know, little, and we can teach people that with, you know, when you are using those oils, really little amounts, trying not to add any extra fat or and keeping your protein, which has a high a fat content, keeping them to a smaller portion, really enjoying a lot of those non-starchy vegetables. And also exercise, they go hand in hand. When you're doing something like this, you still need to be able to exercise as best as you can. And also more weight loss observed with clinician support. When we're there to support people and help and provide that positive aspect, people do find they have a better outcome. There's also improvements in glycemic control, including a reduced HbA1c improved insulin sensitivity, reduced fasting plasma glucose and postprandial glucose, improved cardiovascular risk factors. It's focusing on the low fat, therefore blood pressure and those high LDL cholesterols, and increase of the good cholesterol, preventing heart disease and stroke. Improvements in fatty liver, brain function, gut microbiomes, also a reduced risk in dementia and some cancers, which is something new coming from the evidence, which is great, and decreased overall mortality. So a really, really long list of benefits from this style of eating. Nil associated risks recorded or hypothesized. The Mediterranean diet promotes a healthy, balanced, primarily plant-based diet with less red meat, refined carb, and undesirable food choices. It's one of our specialists. They really find that this is their favourite diet, and so much so we were asked to make a resource for it, and a resource which I'll show you at the end. And yeah, it's again the flexibility of a good healthy diet. It's usually one that I like to discuss with patients more so than restrictive of a diet, and just really emphasising that inclusiveness to that Mediterranean diet. So there's good quality long-term evidence into the diet because of the effectiveness and efficacy of it. It's more reasonable to have. Because the diet is high in poly and monounsaturated fats as well as other food sources, it is considered to help with satiety and can be followed on a long-term basis. People are eating, they're getting fed, they're getting well fed, they're not feeling hungry. It's easier to follow. But it also, as a consideration, we must ensure that the diet can be easily adapted to incorporate a Western style diet and lifestyle. So of course, based on people's preferences, we do support people through their taste preferences and their usual lifestyle. And this is a little snippet of our resource that we made. I think this is available on the primary healthcare website as well. I can make this available as well, and it's basically a little explanation that it's an eating pattern made come from over in the Mediterranean. Why should people try it? How can it help? And what are some aspects of it and inclusions? And it gives some helpful hints and actual inclusions. And there's a little sample meal plan we made, quite tasty. So now that I'm at the end of talking about each of those diets, you can kind of see what my leaning towards, which diets do I promote or would I find have the most benefits, and what I actually personally prefer. And it's usually ones that are inclusive, promote positive aspects of food rather than restrictive nature, where we're going to cut out nutrients and really have people not wanting to follow them long term. And we can call them sometimes a bad diet. They appear all the time. These are some interesting recent ones we found. Well, actually the anti-inflammatory diet I hear, and I've heard that for a long time, but basically it's cutting out foods which cause inflammation, which gluten, processed foods, fried foods, only organic fruit and vegetables allowed. I find that there is still a lot of those sort of things, you know, coming out and about. Gluten should only be restricted if you have celiac disease. Obviously, processed and fried foods are important to limit, but we don't need to only be eating organic, so it's quite specific again. The snake diet, another interesting one. But yeah, eat like a snake. So you only eat 2 hours per day with 22 hours of fasting, or you make up a snake juice. You can see there, so completely unusual, no evidence base, and just complete crazy. I don't think I could only eat for 2 hours a day. And then something like the Dubro diet, where it's a form of intermittent fasting, 12, 14 or 6 an hour windows. I usually say to people, if you found a diet which promises the world with one product or completely takes out a large amount of food groups, then that's a bit of a red flag. Watch out for those, because they're the ones that are generally going to promise the world and not give any good benefit from them. So in summary, there are multiple diets out there, and it is a hard thing to navigate for anyone that doesn't have a background in nutrition. Anyone will give you an opinion on nutrition. There's so many different things out there, and it's really hard for us to work out what's good for us and what's not. There is no one diet fits all approach, and that's why things like the DASH, the Mediterranean diets are so beneficial, because they allow that flexibility but promote good day-to-day eating. We really need clinician support. You know, we need to support each other and promote the messages that are really helpful rather than negative and associated with this is a naughty or a wrong food, or you should stop eating A, B, and C just because you have diabetes. I hear that very frequently. Even the term diabetic diet, I cringe at sometimes, because there is no diabetic diet. It's not a diet you're put on when you have diabetes. It's all about good, healthy eating and understanding what foods affect your blood sugars. Satiety is one of the biggest factors in long-term adherence. If you're hungry and cutting out lots of foods, you're going to be missing key things, or you're going to want more of the things that we need less of. Plant-based diets such as vegetarian, vegan, DASH and Mediterranean are usually really positive. Doesn't mean that if we should be vegetarian or vegan, it just means that predominant plant-based diet is important, and something with a holistic approach, really making sure that we enjoy food, we have positive relationship with food, and make it a social thing as well. So that's the end of my presentation today. You can see some of my details there. Email is probably better if you do have any questions, because that's my general number for the diabetes service. But yeah, if you do need to speak with me, you can get me through there. But I'm happy to answer any questions from now.
Yes, there is. You're bang on time with that presentation. Well done, Emma. One of the questions was, we'll just do a couple of questions, because there's a few that the rest of them I will send through to you via email so that you can answer them that way. There's one just asking, what do I say to clients on insulin who want to try the keto low carb diet to reduce or eliminate insulin requirements?
Yeah, really good question, and probably that's kind of why we made the resource, because a lot of clinicians did ask us that. How do I approach it? And how do I talk to people? And what is the evidence? So there is, you know, you can always use that resource to say, look, this is the available evidence at the moment. It's got some risks associated with very little evidence to support the weight loss ability. Really drive home the I want to keep you safe and make sure you're getting everything you need from a healthy diet, which includes carbohydrate, and not taking the risk of a hypo, or, you know, which no one wants. So referring on to dietitians will support that page as well.
Okay, you're just having some audio issues again, so sorry, Emma. Would you mind turning off that camera? Thanks. And then there's another question about the DASH diet. The slide says up to 6 serves per day. So can it be plant-based?
6 serves of what was that question then? 6 serves of what?
So the DASH diet slide says up to 6 serves per day of meat.
Oh, sorry, didn't hear that bit. Yep.
So can it be plant-based?
Yeah, so that's a good question. So yeah, I think it's a meat or a meat alternative. So, you know, if you're replacing meat, it would need to be something like tofu or nuts, or I'm trying to think, some of the vegetarian based products, lentils, legumes, fish. I mean, some people are vegetarian but they eat fish. So yeah, some of that would probably be the only thing with that dash picture. It doesn't really specify what is included in a serve, so you're not really sure how much is what they're aiming for, because 6 serves sounds like a lot, but it doesn't really specify how much one serve is, so it may be a little bit hard for us to give it a bit of understanding.
Okay, and then there was a few questions about the slides, and I'll just confirm that they will be available over the coming days on our website at the PHN. So it will be under the Education Library. That's where they'll be located. So we've just run a little bit over time. Thank you so much, Emma. I'll forward the rest of the questions to you via email, and Emma will respond to you that way. Thank you, everyone, for being with us tonight. Have a lovely evening, and thanks again, Emma. That was a really interesting topic, and enjoy the evening, everybody.
Thanks very much.